Well, welcome everybody to the launch of the Creative Health Research Roundup 2025. Hopefully you have all received a link to the full report and the summary, which Alexis sent in an email, but she'll also put it in the chat now. If you're spreading the word via LinkedIn or Blue Sky, please tag NCCH, and we'll also put that in the chat. Please also say who you are in the chat so that we know who's here. And just to say that live captions are switched on if you would like to use them. When it comes to the Q&A, we'll be using the Q&A function in Teams, which is at the top of the screen. You can see it says Q&A there, rather than the chat. So please put your questions in the Q&A box. You can put your questions in at any time, but we will be doing the questions after all the speakers. I'm sorry we can't see everyone, but as I said, there are around 570 people signed up for this event. We've currently got around 180 in the room, and more people are coming in all the time. But we will be sending out the recording. So if people haven't been able to join, they will get a copy of the recording of the event. So I want to say a big thank you to you all for being here today, and a huge thank you to Dr. Jane Hurst, who is our research and policy manager, who has managed the whole process of the call out, the selection and the publication. She's worked incredibly hard to bring this report together, and it has been quite a mammoth task, as I'm sure you will appreciate when you have a look at it. And thank you to all of those who contributed to the research, everyone who is in the publication, and of course to our speakers today, which is a small selection of those authors. I imagine quite a lot of the other contributors are in the audience, and we'll have that chance to discuss a bit more about the report and the contents at the end in the Q&A. I'm Alex Coulter. I'm Director of the National Centre for Creative Health, and I'm here with Professor Susan Hogan, who is Chair of the Royal Society for Public Health Special Interest Group in Arts, Health and Wellbeing. I'll be introducing the speakers, and after they have all given their presentations, Susan will chair the Q&A. We have all the speakers in the room, as well as some of their colleagues who will join in the Q&A. And we have Dr. Jane Hurst, who I've already mentioned, and also Professor Helen Chatterjee, who helped with the selection process. We have 7 speakers, 7 presentations, and they have all been asked to speak for no more than 7 minutes, which gives us a short time between slides, between speakers rather, to change the slides and so on. And I will indicate to speakers when they have 1 minute left. If anyone in the audience needs to take a break, please feel free to do so, because we are recording the session, and we will be sending that recording to you. So don't worry about missing any of the presentations. Great. Okay, so we're going to start with presentation 1, which is Dr. Lynette Meredith, who is a specialist clinical psychologist, and she is going to be talking about her research, crafting lyrics, breaking barriers, exploring the role of rap music in facilitating mental health expression among Black men in the UK. And I think Jane is going to share Lynette's. I'll pass over to you, Lynette.
Amazing. Thanks very much for the introduction. Hi everyone, I'm Lynette Meredith, a clinical psychologist working in forensic inpatient services in West London. Today I'm sharing the findings from my doctoral research, which explores how Black men in the UK use rap music in their everyday lives to express and manage their mental health. And so the idea for this research came from my work in prisons. I noticed that some of the young Black men I worked with spoke far more openly through creating rap music, as opposed to how they did in traditional therapy spaces. And so my study centres Black men's own creative practices and looks at what rap offers psychologically outside of formal services. Next slide, please. So why does this matter? Black men in the UK experience significant mental health inequalities, but are much less likely to access mental health services. And this means that support often happens at crisis point rather than early on. This lack of engagement is sometimes framed as reluctance, but research shows it's more about racism, stigma, restrictive masculinity norms, and long-standing mistrust of services that have caused harm. For many Black men, services feel unsafe, inaccessible, or culturally disconnected, which highlights the need for preventative and culturally meaningful approaches to mental health. Next slide, please. And why rap? So rap is a part of hip hop culture, rooted in Black storytelling, resistance, and community. In the UK, subgenres like grime and drill reflect the lived experiences of Black communities, including racism, inequality, and trauma. Research has shown that rap has increasingly become a space where mental health is discussed, and rappers talking about their own mental health has been shown to open up conversations among Black men. There have been rap-based interventions developed in the US, such as rap therapy and hip-hop therapy, and they integrate rap with existing therapy models like cognitive behavioral therapy. And research exploring those interventions has shown some positive outcomes for mental health. However, a lot of the existing research looking at rap interventions has been delivered in institutions like mental health services, the education system, and prisons. And much less is known about how Black men use rap in everyday life as a self-directed way of coping. And that's the gap that this study aimed to address. Next slide, please. So my study explored how and why rap supports mental health and self-expression. It involved 11 Black and mixed heritage Black men aged 24 to 51 living across the UK. And they all created rap in different ways. So some of them wrote lyrics, performed, produced, and facilitated workshops in the community and prisons. And they recruited through social media and also with the support of community music organisations. Participants took part in semi-structured interviews, and the data were analysed using reflexive thematic analysis, which allowed me to look at patterns in the data set and for meaning in the data set, while also being attentive to broader contexts and my own reflexivity. So any biases that might have arose from me looking at the data relating to my personal and professional experiences. So with regards to the findings, three main themes emerged. So the first theme was rap as therapy. So participants described rap as a form of self-therapy and medicine, helping them to cope with experiences like bereavement, homelessness, and heartbreak. Rap allowed for self-expression and emotional release, offering a healthier coping outlet than options like alcohol. Rap enabled participants to reflect and gain self-awareness and insight into their problems. But at the same time, participants reported that rap has limits and that external or professional support is sometimes necessary to address their problems. The second theme explored how rap helps to navigate vulnerability, masculinity, and stigma. Participants described a pressure to appear tough and emotionally restricted, which was shaped by various cultural and gender norms. Rap provided a socially acceptable space for vulnerability, and mistrust of systems like the NHS or the police encourage more self-reliance through rap and a reluctance to seek help more formally. Rap acted both as an emotional outlet and at times a protective shield for what couldn't be said to other people directly. And the shield that participants talked about included the use of having a rap persona and also using things like metaphor to mask the meaning behind their lyrics. The final theme was rap as connection, validation, and social influence. So rap fostered belonging and connection through shared experiences, which helped participants to build community and friendships. Seeing other Black male rappers express vulnerability normalised participants' own challenges and encouraged emotional openness. Participants also described using their rap lyrics to support others by offering comfort, motivation, and raising awareness about mental health and social issues. This suggests that rap can have both personal and collective mental health value. So in terms of the implications, this research suggests that RAP can act as an accessible and preventative entry point into conversations about mental health, particularly for Black men who struggle to engage with formal support. Rather than replacing therapy, RAP appears to work alongside it, offering a culturally meaningful way to cope with challenges and build connection, all within the constraints of masculinity and cultural norms. This aligns closely with community-based approaches and social prescribing initiatives, and is particularly relevant in the context of the new NHS 10-year health plan, which emphasises prevention, community partnerships, and tackling inequalities. There are lots of amazing community music organisations doing great work, but they're often under-resourced. And the findings point to the value of collaborating with those organisations, but also with Black male rappers and artists who could help to encourage and normalise self-expression and help seeking among Black men. It's really important to say that this must avoid any tokenism or appropriation, and any use of rap in mental health spaces needs to be co-produced, led by the community and also grounded in respect for hip-hop culture. And finally, this isn't a one-size-fits-all solution, so rap won't resonate with every Black man, and Black men aren't a homogenous group. But I hope that my research highlights how culturally grounded approaches can widen the ways we think about prevention and engagement.
1 minute to go, Lynette.
Just wrapping up now, but just to finish off, I've kind of gone through that very quickly, but if you would like to read more about my study, I've got a QR code here with links to the full thesis and also a study handout summary that I put together, but also my contact details if anyone has any questions after today. But just to say thank you for giving me the space to talk about my study today, and I look forward to taking questions later.
Thank you very much. That's great. Well, lots of hearts and claps coming up there, which is lovely. Okay, well, we're going to move straight on to presentation 2 now, and that is Dr. Tanya Acaron, Director and Dance Movement Psychotherapist, the Body Hotel CIC, course leader on the MA Arts, Health and Wellbeing at the University of South Wales, and her research is the Body Hotel Self-Care Suite Evaluation. Over to you, Tanya.
Thank you so much. Really excited to present to you a little bit of the findings of this evaluation report. I'm also cognizant that this is the evaluation report conducted by University of South Wales and the Wales School for Social Prescribing Research, and Dr. Teresa Filipponi and Professor Carolyn Wallace are not able to present alongside, but I wanted to credit them and their amazing work in evaluating this intervention. And today we're going to be talking about some of the benefits of movement-based interventions for staff well-being. I'll tell you a little bit about the Body Hotel, which is a social enterprise based in Wales, and we design bespoke training and staff well-being days and full programs based on self-care strategies, burnout and compassion fatigue prevention, using dance and movement as the sole focus. And then we're collecting a plethora of research about how important the role of the body is in understanding kind of wider discourses of well-being and the importance of nonverbal interventions in this regard. And so this is one of 4, the one I'm going to present to you, one of 4 programs that we've had funded through Arts Council Wales and the Arts Health and Wellbeing Fund in collaboration with several different health boards across Wales. And right now we've just wrapped up a project about menopause and movement for well-being. And so just wanted to bring you a little bit of a context of why movement. There's been a recent report by Bangor University looking at how arts programs and can support the health and well-being staff and can save up to 3.5 million a year. So this is a really brand new report that just came out. In 2023, we conducted the first social return on investment study in dance conducted in the UK. And we found that for every £1.94 pounds to 2.32 per £1 spent. So it's looking at all the benefits, and there was an overall improvement in mental health and well-being. And so this program had 3 different offerings. So we did an embodied skills in clinical practice. So we offered that as part of the staff meetings. So we kind of went into the different staff teams, focusing on allied health and therapies teams, and particularly around palliative care. So Velindre NHS Trust was our partner in this project, and they were really keen to support palliative care and looking at new different embodied skills that the staff could take on and could translate into their own team building and cultural cohesion, and also into the work with their clients and patients. And then we also offered, and we're doing that ongoing anyway, an open level workshop and more 3-hour sessions open into the community, which served as a separate part of this evaluation. And then we used a mixed methods evaluation approach. There were 10 evaluation participants and stakeholders. Dr. Filipponi conducted online semi-structured interviews. And then the Body Hotel, with 43 participants and stakeholders, we had a pre and post intervention, a questionnaire called the Neuroception of Psychological Safety, which is a scale. I'll talk a little bit more about the scale in a second. So then we then supplied that data collection to the Wales School for Social Prescribing Research to conduct the data analysis. But as a whole, we were able to reach about 79 participants through our community events and also our kind of large-scale conference presentations. And the Neuroception and Psychological Safety Scale is now managed by the Kinsey Institute of Traumatic Stress Research, which is also part of the Polyvagal Institute. It's one of the few validated scales that focus on body-based symptoms, which has been quite a big challenge when we're working on trying to measure the impact and the importance of dance movement. And so it has 3 different subscales, which directly related to the project. One was a social engagement, which looked at acceptance and feeling heard. The other one was about compassion, because we're kind of working and focusing on compassion fatigue and looking at empathy and motivation to care. And then an interesting, right, the uniqueness of the scale looks at bodily sensations. And so there's some really interesting research around how in compassion fatigue, the primary indicators are body-based symptoms before cognitively we understand that this is happening. So based on that, then they conducted a thematic analysis which generated 4 different dimensions for the evaluation report. And I'll have a link to the evaluation report for you as well. Mostly looking at one of the interesting aspects of that was the professional practice, which is, of these 4 themes, the one that I wanted to just highlight a little bit today. They were some of the staff teams that were that brought up to us a need to integrate different cultural groups within their nursing departments. And we found that actually engaging in movements really helped with supporting more connections and more cultural cohesion within the NHS. And then there was another highlight around transferable tools and looking at the fact that some of the skills that we went through in the different interventions, that staff were able to take those self-management techniques into their week, into even staff rituals, like we had a movement break, for example, to help break up the day, to help shift some of the energy, and also to allow space to recover within very high pressure systems.
Tanya, just less than a minute now.
Yeah, of course. And then some of the learnings were in terms of this, some of the resistance to bringing dance and movements. I'm from Puerto Rico, so we're coming from I come from a very dance-based culture, but trying to integrate that into the staff meetings was an interesting one. But after people could see the effects of this and the applicability, there was less resistance and more acceptance, actually, and more understanding of dance movement interventions as a whole. And then what are the future aspects is to be able to integrate this into as an ongoing practice within staff teams, and then we're expanding right now in digital and remote delivery options. So looking at, now we're focusing on menopause at the moment and looking at that intersection with Valindra. And so just wanted to end a little bit with just saying, just thanking the funders. And if you want to have more information about all our projects, I'm leaving our information here. So thank you so much for the opportunity.
Thank you very much, Tanya. Thank you. That's fantastic. Okay, so we started quite quickly, so we aren't losing time. So presentation 3 is Dr. Charlotte Hemingway, postdoctoral research associate at the Liverpool School of Tropical Medicine, and the research program is Recite, a theory of change for health equity through creative health. So over to you, Charlotte.
So health inequity is a wicked problem rooted in misinformation, mistrust, and trauma. And to solve a wicked problem, you need people with different expertise and viewpoints, especially those who are directly impacted by the problem. You also need to provide opportunity for these people to work together, while giving them the license to trial new approaches and the capacity to test what's working and what's not. Now, we know creative health can be used to good effect to chop back the psychosocial roots of inequity. We've heard, and I'm sure we'll go on to hear some fantastic examples of that impact today. But if we're going to realise the full potential of creative health, we need a health system that encourages and supports collaboration, a system that rewards innovative and creative thinking, and a system that enables us through long-term commitments to move beyond pilots. In other words, we need a social movement. Now, the question is, can we fuel this movement with community-informed innovation and storytelling? So we began filling our metaphorical fuel tank by bringing together key stakeholders from across Merseyside to develop a programme of research. Through a co-production process that's illustrated here and described in our paper, we collectively explored how storytelling can be used to motivate and connect actors to affect change across different levels of the health system. And we also discussed ways to evaluate these approaches that looked beyond traditional metrics, in recognition of the fact that health outcomes are often complex and relational, while still aspiring to generate robust evidence of public health impact that could influence system decision makers. Now, this process was undeniably valuable, as it resulted in a research-ready consortium that went on to receive funding. It did, however, require a lengthy, iterative process to effectively build trust and understanding and consolidate input from different experts. And this, in turn, made it difficult for some stakeholders to fully engage in the process. Now, despite this running theme of resource and system constraints, the Recite Consortium has gone on to make significant progress in delivery and evaluation of a story-driven social movement to tackle health inequities in Liverpool City region. The Recite programme consists of 5 distinct interventions and is presented as a wheel to illustrate how these different activities interconnect and feed into each other to form a movement. Led by Writing on the Wall, the What's Your Story programme provides space and creative resource to support people with lived experience of health inequities to tell their story. And connecting the people and their stories to key decision makers are the advocacy networks led by Collective Encounters. And linked to these is a programme of co-produced research to try and unpack the individual and policy level impacts of these activities. Now, this picture is a great illustration of what storytelling for change can look like in action. Through What's Your Story, we have engaged 26 people and built their confidence to turn their lived experience into powerful collective art pieces to advocate for change. Inspired by these stories, collective encounters will use theatre to connect communities with decision makers to effect change at the policy level. Operating at the community level are community innovation teams. These are local partnerships between health providers and community representatives who are empowered through tailored coaching and mentorship by global health experts to use local data and storytelling to effect change in health services and the community. And through the linked programme of research, we will explore if this activity can lead to specific measurable changes in health equity indicators. Now, community innovation teams, or KITs for short, are multidisciplinary teams which sit at the interface between communities and health services. But let's be honest, collaboration in this space isn't easy. Getting the right people at the table and working together requires mobilisation, relationship building and problem solving, which is why Recite has its own team of community mobilisers who work closely with the KITs to help them navigate the trials and tribulations of collaboration. KITs are supported then to use local routine health data to identify a health equity gap and collectively develop a problem statement that is targeted and measurable. Local insight gathering is deployed to address gaps in understanding and test assumptions. And by leveraging local knowledge and the trusted position of KIT members, insights can be gathered rapidly using methods that are accessible and engaging. In one case, this resulted in some fabulous Play-Doh interpretations of the measles virus, sculpted by primary school children in Knowsley. The KITs then use this combined routine health data and community insights to seek out the root causes of the problem that are within their power to address. And they are also given license to trial creative interventions, forming health initiatives that feel different from the norm and grounded in the communities that they serve.
Charlotte, 1 minute.
Recite is currently working with 12 KITs across Merseyside, covering a wide range of health topics chosen by local stakeholders. On the screen is a map of Liverpool City region, demonstrating the geographical spread of the KITs, each with their own unique story to tell. And to harness all of this creativity going on in the region, the final 2 interventions are platforms for networking and knowledge exchange, as well as a linked programme of research to explore whether these platforms and the stories told within them spark collective action across sectors and the different levels of the health system. Our inaugural Creative Health Exchange last year marked the beginning of the movement. Hosted in the iconic Liverpool Lighthouse, this vibrant event brought together local stakeholders to share best practice and imagine new ways of working together. We're now in our final, most exciting year of Recite, and we're working hard to keep the momentum up. We've got planned journal publications delivering robust evidence, and we're really looking forward to our upcoming creative health strategy that's planning to be even bigger and better, which is going to be running in September and delivered in partnership with Liverpool City Region Combined Authority, which means we're feeling really confident this work will help lead to some real measurable system change. I'd like to finally finish by thanking everyone that has helped drive this research and social movement forwards. Thank you everyone for your time.
Thank you, Charlotte. That all sounds very exciting. We look forward to hearing more about the strategy. Okay, so we're now moving on to presentation 4, which is Dr. Katie Hazelgrove, postdoctoral research associate, King's College London, And the research is clinical effectiveness, implementation effectiveness, and cost effectiveness of a community singing intervention for postnatal depressive symptoms, SHAPER PND, randomized control trial. Over to you, Katie.
Thank you very much for the introduction, and thank you for inviting me to present today. So the research I'm going to be presenting is part of a wider research programme called SHAPER, and that stands for Scaling Up Health Arts Programmes, Implementation and Effectiveness Research. And this is a large Wellcome funded initiative to assess the effectiveness and implementation of 3 arts in health interventions. And for today's talk, I'm going to be focusing on some recently published findings from our postnatal depression arm of the SHAPER programme, or SHAPER PND. And this was a randomised control trial examining the clinical effectiveness, implementation effectiveness, and cost effectiveness of a community singing intervention for women experiencing symptoms of postnatal depression. So around 1 in 4 new mothers will experience postnatal depression in the UK, and if left untreated, it can have long-term impacts on both maternal well-being and infant development, as well as affecting the quality of the mother-infant relationship. And while psychological therapy and medication are considered the gold standard treatment, many mothers with postnatal depression will experience challenges when it comes to accessing care, highlighting the need really for alternative interventions. And recent studies have shown the benefits of group singing for improving maternal mental health and promoting the mother-infant relationship. And that is where Breathe Arts Health Research and their programme Breathe Melodies for Mums comes in. Now, Breathe Arts Health Research are a multi-award winning not-for-profit social enterprise, and they deliver evidence-based programmes across a range of different art forms. And Breathe Melodies for Mums is one of those programmes. And it's based on research by the Royal College of Music and Imperial College London. And it showed that weekly group singing could improve symptoms of postnatal depression faster than play or care as usual. And Breathe Melodies for Mums is really unique in that it's designed to put mums right at the heart of the session. So these are nursery rhyme-free zones, and they have specialist singing leads who use a repertoire of international songs in a range of languages, so very accessible to mums from different backgrounds. And they deliver these across a 10-week programme. And so the aim of the SHAPER PND trial was to investigate on a much larger scale than has previously been done, whether 10 weeks of Breathe Melodies for Mums group singing intervention was firstly an effective treatment for postnatal depression, secondly acceptable to mothers, and thirdly cost effective for the NHS. So to address these aims, we recruited 199 mothers with symptoms of postnatal depression, and this was measured using the gold standard Edinburgh Postnatal Depression Scale, or EPDS. And mothers were recruited with their babies who were aged from birth to 9 months. And the participants were then randomly allocated to either receive 10 weeks of the Melodies for Mums intervention or to an active control group. And that meant that they were signposted to another mother and baby activity in the community. So that might be something like messy play. And they were then offered the Melodies for Mums sessions at a later stage. And the participants in the study completed questionnaires and interviews at baseline at week 10, so that was the end of the intervention, and then at weeks 20 and 36, so those were post-intervention follow-ups. And this enabled us to assess their mental health, but also to measure the implementation and cost effectiveness of the programme. So if I move on to the findings now, and our first aim to evaluate the clinical effectiveness of Breathe Melodies for Mums. And we did this by assessing the change in the depressive symptoms measured with the EPDS from the start of the study through to week 36. And you can see that presented in the figure here. And we found that participants in both groups, so both the singing and control groups, experienced a reduction in their depressive symptoms during the intervention period. So that's that part of the graph highlighted in red. And both the singing group, that's the solid black line in the figure, and the control group in the dashed grey line, showing a reduction in their EPDS scores during that intervention window. However, it was only the participants in the singing group that continued to significantly improve following the intervention. And we found that they had significantly lower EPDS scores at weeks 20 and 36. So this is really demonstrating the long-lasting effects of the singing intervention up to 6 months after they had finished. So our second aim then was to look at the implementation effectiveness of Breathe Melodies for Mums, and the results of this are presented in the table here. And we can see here that compared to those in the control group, participants in the Melodies for Mums group rated their sessions as being significantly more acceptable. So this is suggesting that the singing sessions are agreeable, they're palatable, they're satisfactory, that they're significantly more appropriate, so they're fit, they're relevant, they're suitable for these mothers who are experiencing symptoms of postnatal depression, and that they're more feasible. So this suggests that the sessions are practically doable, that the singing is successfully used and delivered to the mothers with postnatal depression. And then finally, we looked at the cost effectiveness of Breathe Melodies for Mums. And we firstly found that the participants in the singing group gained around 15 additional days in full health over the 36-week study period compared to the controls. We then evaluated how much the Melodies for Mums programme would cost the NHS or local authority. And we found that estimates ranged from a lower cost of about £126 per mother baby pair per programme, so that's for all of the 10 sessions, to an upper cost of around £539 per mother baby pair per programme. So suggestive of quite reasonable costs. And indeed, when we look at these costs relative to the type of interventions that are currently prescribed by the NHS for mothers with postnatal depression, and that's what we can see presented in the figure here, we find that the cost for Melodies for Mums, and that's represented in those two darker blue bars in the middle of the figure, this falls well within the range of published estimates for currently prescribed interventions. And you can see in the figure here, they range from around £7,000 for telephone-based peer support, that's the column on the left, to £66,000 for listening home visits, shown in the column on the far right. So we're well within that range. But perhaps most importantly, this range fell almost entirely below what the UK health regulator, so the National Institute for Health and Care Excellence, or NICE, recommends that the NHS should pay for healthcare programmes.
Katie, less than a minute.
Okay, thank you. So just to summarise the findings, Breathe Melodies for Mums had a long-lasting effect on symptoms of postnatal depression. It was perceived by the mothers as being more suitable than existing activities, and it represents a worthwhile investment for healthcare systems as an intervention for those who are experiencing symptoms of postnatal depression. And I'd just like to end with this slide, which includes details to the full article. This was published at the end of last year in the British Journal of Psychiatry by my colleague, Dr. Rebecca Beand. If you're interested in reading the results in a little bit more detail. And you can also scan our QR code here for further details of the Breathe Melodies for Mums programme and all of the research that we've published on that to date. So thank you very much.
Thank you very much, Katie. I think I saw someone's hand come up. Please, could you put questions in the Q&A box, and they will be picked up afterwards. Do write them in now, because in case you forget them, if you want, especially if you want to ask a question to an individual speaker. So we'll come back to questions after we've heard from all the speakers. I hope that's okay. Okay, so now we're moving on to presentation 5, which is Dr. Chloe Bradwell, who's postdoctoral research fellow at Leeds Beck University in the Centre for Dementia Research. And the research is called Not Lovely, Enacting Solidarity in Dementia Care Through Participatory Arts. Over to you, Chloe.
Thank you very much for having me today. So, I would like you to imagine walking into a care home lounge where everyone is just enjoying themselves. There is music, people are laughing, the atmosphere is warm and playful. Then one of the residents, who I'm going to name Simone, who was just assisted to go to the toilet, comes in, and she says with a very sad voice, they never change me. Simone isn't saying this to be difficult. She's upset because she's not feeling clean. And suddenly the question in the room becomes, do we rush to distract her and get back to the cheerful atmosphere? Or do we make space for what she's feeling? Because what's happened next shows something really important. And that is that sometime in dementia care, the most meaningful connection doesn't come from staying positive. It's actually come from meeting the hard emotions. So I'm going to share with you one small example from an arts program in a care home that comes from my PhD research. And I will talk about what this example shows us about why negative emotion like sadness and anger can be meaningful communications, how artists can respond through the body, not just words, and how that kind of response can create something bigger than comfort, which is solidarity. This example comes from NCCH Art. They are an art company based in London, and they work with people with profound and multiple disability, as well as care home residents. They run a long-term program in care home, which is called Walking Through Wall. So that program isn't therapy in the clinical sense. It's not a craft activity either. It's improvisation, movement, voice, music, and really responding to what's happening in the room. And the program that I researched took place in a care home in London, and it was led by 3 artists with skill in improvisational movement and music. So in the morning, artists would work with bedbound residents, and in the afternoon, they facilitate group session in a private lounge, usually working on improvisational performances. And I'm going to be focusing on one of those group sessions. So let's go back to Simone, our resident who has just returned from the toilet. She's re-enters the room, and the care staff place her in a circle with other residents. And at this moment, people have been taking turn in the circle, singing the word lovely in different tone of voice. So it sounded like lovely, lovely, lovely. But when her turns come, she actually breaks this pattern. And instead, she says, they never change me. So there is a staff member here who is trying to reassure her, you have been changed. But Simone repeats it again, they never change me. And she sounds really sad. So now here is a turning point. The artist could have tried to pull her back into the lovely atmosphere, but instead they do something unusual. They join her. And one of the artists physically brings his body down to her level, and he softly sings her work back in a low melancholic tone. They never change me. And this is what I call in my article kinesthetic attunement, which is basically just a fancy way of saying tuning in through the body, so the person feels met and not managed. And here the artists aren't debating whether Simone is actually right and whether she's been changed. They are saying with their bodies, we hear you, we are with you. Then something even more surprising happens. Simone's sadness progressively sharpens into anger, and her fist clenches. So one of the artists brings over a cushion and he offers it to her. Do you want to hit this? He asks. Simone starts punching the cushion, and the group cheers her on. And the artists notice this and open up this energy to the rest of the group. So people raise their fists, punch the air, shout, and they let go of their own frustration in a playful way. And even the staff member join in. So what would normally be labeled as challenging behavior gets reframed here as expression, connection, and a collective moment. And this is where the word solidarity matters. So empathy often means I feel for you. Solidarity is closer to I'm alongside you and I'm taking your reality seriously. And in care setting, people living with dementia are often expected to perform pleasantness. So if they're distressed or angry, it can be treated as a problem to eliminate, sometimes with isolation, sometimes with medication. But what this moment suggests is that well-being is not the same as constant happiness. And sometimes well-being looks like being allowed to be upset and being responded to with respect. And solidarity can happen in tiny ways, not by fixing that feeling, but by making room for it and by letting the group carry it together. So what do we do with this? Well, one takeaway for anyone involved in care is that when someone living with dementia expresses distress, the first question doesn't have to be, how do I stop this? It can also be, what is this trying to tell us? And that day in the activity room, lovely wasn't the only emotion that loaded in. Sadness showed up, anger showed up. And instead of being shut down, those emotions became a bridge. And that didn't happen by accident. It was only made possible by an embodied creative process, artists listening with their own body. So maybe the real question is then, how do we make dementia care happier? Maybe it's how do we make it more human? Because sometimes being more human means being brave enough to stay with what isn't lovely together. Thank you.
Thank you, Chloe. That's brilliant. Thank you. Okay, we're moving quite fast through, but that does mean we'll have more time for questions, Susan. So, you know, that's good. So the next presentation is from Miss Sophie Beckett, who is Public Health Research Officer at Birmingham Museums Trust. And the research is Using Oral Histories, a Methodology for Public Health Advocacy. Over to you, Sophie. Thanks.
Brilliant. Thank you. There we go. Thanks for that introduction. So I'm going to talk about a 2-year programme that has been funded by Birmingham City Council Public Health Department, which funds my role as a Public Health Research Officer based at Birmingham Museums Trust. I ran a whole set of interventions during this time that I've been here over the 2 years. And in the interest of time, I'm only going to focus on one. But it all revolved around one particular oral history collection, which is to do with food and drink. And this collection was used as a springboard for multiple different interventions, primarily around a tool, using it as a tool for health literacy. So this is just an example of some of those interventions, but I'm just going to focus on this one here, which is based in a gallery space. So as I mentioned, we've got a large collection here at Birmingham Museums Trust, 9 sites, over 1 million objects and around 3,000 oral history recordings. But I just looked at this one oral history collection recorded in 1984, and it was a selection of people talking about their food practices, often people who were already involved in the food industry, so restaurant and cafe owners, food inspectors, etc. So what I wanted to do with this oral history collection is think about how we could use it as a springboard to have conversations around contemporary habits and behaviours in particular. So what I did was curate 10 snippets of these oral histories and put them in the gallery in this space pictured here. And I had a couple of sort of health-related prompts alongside each snippet. And then I positioned 3 questions to visitors to respond to. So what does good food mean to you? How easy is it for you to eat healthily where you live in Birmingham? And what makes it tricky for you to eat healthily? And the resources that I put in the space were comment cards, little A5 pieces of paper, pens, and then a map here that you can see, which is a ward map of Birmingham, and some sticky dots to add on to the map. And these 3 questions are adapted from a behaviour change model called COMBI, which is an individual's capability, motivation, and opportunity to be able to, which impacts their behaviour. And I chose these questions because I felt they were accessible and adaptable for a kind of museum audience. So this exhibition ran for 6 weeks, and there were over 1,000 instances of participation in that time. And I am going to focus primarily on the mapping, but I just wanted to show you that people responded differently to how I expected. I expected purely textual and sticky dot interactions, but I got loads of drawings. So people expressing their eating habits and behaviours through these drawings as well. And I have analysed these in a different paper, but in the interest of time, I'm just thought I'd flash them up to show you what kind of ways people engage in these creative spaces. So on the left here, you can see the participatory mapping data that came from the exhibition space. So in response to the question, how easy is it for you to eat healthily where you live in Birmingham, the red dots indicate that it's very difficult. The yellow dots indicate that it's complicated, and the red dots indicate that it's very easy for you to eat healthily in Birmingham. So I took this data and then aggregated it here into these maps, as you can see, so indicating sort of hotspots for food insecurity. And what this data shows is perceived food insecurity. So this is based on people's lived experience and what they feel about that particular area that they're living in. And I then compared this data with objective measures, so ward level data on obesity, deprivation, and priority places for food index, which is basically a composite score looking at food insecurity. So here you can see the perceived food insecurity on the y-axis, which is the data from the gallery, and the PPFI data, which is this objective food insecurity data along the x-axis. And you can see a correlation here between what people have suggested about their food insecurity in those wards and what the objective data shows as well. And what this means is that we can rely on, in this instance, we can rely on data that's been developed and given by participants in this space to understand food insecurity, and because of this correlation between the two sets of data. What was also really interesting is that some of these wards have potentially higher perceived levels of food insecurity related to the objective measure. So the priority places might not think that it's a ward that's sort of high on the priority for food insecurity intervention, but the data suggests actually the people in these areas are facing issues around food insecurity. And often this perception of food insecurity is a measure of anxiety and worry and short-term changes that aren't reflected already in the structural data that's presented from the PPFI. So what does this mean for health systems? So I took this data and this work to the public health food team at Birmingham City Council, and we had a long conversation about how they might be using the data. And within the data itself, the mapping data, they were talking about how lots of areas in Birmingham are affected by food insecurity, but the contextualized specific wards that were identified through this work are going to be the kind of pinnacle wards moving forward for intervention as part of their work. They also are really interested in the methodology. So because this is a sort of scalable method that can be used to gather real world data with lots of different health conditions and healthy behaviours, it's been picked up by other areas of public health and also by a couple of different university departments that are interested in understanding lived experience through health. And there's a suggestion that this is going to be used in community centres moving forward. Also wanted to highlight the impact of co-production in this work. So it sort of highlights the process of using lived experience collected through mass participation as this tangible, reliable source of data in health research, which makes health kind of systems more relevant and effective for the people that they serve. And also we used a system of public contributors throughout this work. So it sparked conversation within our own museum about how we can democratize decision-making processes around our displays and what we present. And I just wanted to summarize by talking about the value of this work and what I felt was really interesting and relevant. So the creative methods, we found that there were far more instances of people sort of relating their cultural experiences through drawings and then in the textual responses. So being able to have drawings, sticky dots, etc., as a really accessible way of gathering data. This was a really well participated exhibition for us. Over 1,000 instances in 6 weeks is significant in that space. It was also very resource efficient and cost efficient. I let the exhibition run as it was, and there's no specialist knowledge required for participants in order to respond to the exhibition. It also served to think about museums as trusted non-clinical spaces that are capable of breaking down kind of quite complex topics and conversations to make them simpler and understandable for everybody, and also thinking about the kind of diversity of our audiences that we can impact as well. And finally, by focusing on upstream determinants of health, we think more kind of pre-prevention, so thinking not just about how we can prevent or manage illness and well-being, but how we can contribute to the conversation, understanding these conditions and sort of structural determinants in the first place, which I think positions heritage spaces as active infrastructures for understanding lived experiences and using that as guiding intelligence to inform prevention, not just as a place for learning and wonder, but also to advocate for the health needs of the city. Thank you.
Thank you, Sophie. Thank you. That's great. Okay, thank you. And we are now on to our last presentation, presentation 7, which is Professor Maria Chatzichristodoulou. I don't know if you're here, Maria. I'm sorry if that name pronunciation is wrong, but I wasn't able to check with you in advance.
Very good. Thank you.
Thank you. Nice to see you. Over to you then. Oh, sorry, I haven't said the name of your research. So, Maria is Dean of Research and Knowledge Exchange at Chelsea, Camberwell and Wimbledon Colleges of Arts. And the research is Abundance Project Interim Findings Report. Over to you, Maria.
Thank you very much. I'll briefly talk you through what we have been doing at the Abundance Project, which is one of 12 projects funded by UK Research Council and AHSC as part of the Mobilising Community Assets to Address Health Inequities programme. And the purpose of the Abundance Project is to find ways to enhance cultural and green inclusion in social prescribing. And our focus is in southwest London, but we very much are thinking about how our interventions can be sustainable and scalable in other contexts. So why are we doing this project? We know that Black and minority ethnic and refugee communities are most at risk of poor mental health. We also know they are least likely to use cultural and green assets to improve their health and well-being. So the project promotes an abundance mindset, and that's where the title comes from. We want to recognize the assets, skills, abilities, and resources that exist within the communities. And the team that you can see here is a number of academic colleagues, also community leaders who are co-investigators on the project, and about 30 lived experience experts or LEXperts. So the project, the combination of that team ensures that the project outcomes will be relevant and sustainable because they're co-shaped by the participants' needs and experiences. And again, this is kind of a starting point. Those are the communities we're working with. It's primarily in southwest London, in Feltham. We're working with North Korean refugees in New Malden, and refugee communities in Kingston. We're working with the Asian Resource Centre in Croydon, and also some Black minority communities in Croydon as well. And we're looking to understand what are the assets that are relevant to those communities. And by cultural and green assets, we're talking about museums, cultural institutions, libraries, parks, waterways, community arts groups, etc. And we're looking to connect those through social prescribing as well as voluntary and community sector. I'll talk you through. The project is at the end of its second year. It's a 3-year project, and it will be 3.5 years now. And I'll talk you through the first kind of work packages, if you like, the first piece of work that we've delivered and the methods that we've used and some of the things we found out. So we started using lived experience storytelling as one of our methodological approaches to build relationships with community experts and to establish a community of practice. And we worked with the co-investigators and our community researchers to design and adapt ethical approaches for them to go out into their communities and gather stories and experiences and testimonials from their communities around mental health challenges and how engaging with cultural and green assets may help with those challenges, and what are the barriers of engaging with those assets or accessing those assets. We collected 141 stories and 13 letters that those community experts wrote to their communities. And when I say stories, I just want to emphasize that I'm not just talking about words, I'm talking about all kinds of stories. Some were visual, some were in different languages. So some were long, some were short. So it's all a whole range of inputs. And we applied a thematic analysis to that material that we collected from our communities to understand which are the key themes that come out, which are the themes that matter for those communities. And this is what we found. It's about struggles of being a migrant, mistrust of institutions, constricted knowledge within communities, sometimes around issues to do with mental health, issues of safety, which are even more exacerbated at this point in time, nature and culture understood as sanctuary for mental health by those communities, and the importance of community connection and belonging, as well as cultural difficulties in accessing those assets. Here are just some testimonials, some of extract from the stories that we collected in people's own voices. So some people talking about accessing social services and how challenging this has been. People talking about the taboo of suffering with mental health within those communities. Why ethnic minority communities perhaps tend to want to be together kind of in numbers so as not to be an easy target, particularly when talking about access of green spaces. Also the solace and tranquility that being in those environments can bring, particularly for this mum of two small kids, for example, trying to escape a tiny flat in a dark day, and so on. So that really rich materials and really kind of looking at it as a data set, but also as creative expression. Other methods we applied were community walks and asset mapping. So we went out and we walked around those areas with the communities, and we applied different methods as well to do with focus groups and interviews, etc. The purpose of the walks was to map hyperlocal and culturally specific, suitable or attractive assets. And it was really interesting because we found some of the assets we'd expect, but also things like, oh, that green pond over there where people go fishing, or community groups and shops, ethnic shops, etc., that are really not visible always to social prescribers and social prescribing platforms, for example. We also, through the walks, we mapped some of the barriers to access. And we wanted to establish how information is accessed and used by link workers and other stakeholders, and what types of information is used. And so how we can improve digital asset mapping systems and referral tools to enable better access to those assets. Finally, at the moment, we're through a co-design process. We took all the learning and findings from the first 2 years of the project, and we are trying to develop together with our communities interventions that will help address those issues. So, of course, I don't want to preach to people here understand the value of co-design in bringing together multiple stakeholders, people with lived experience, and to develop solutions that are needs met and through a collaborative process. So we are in the process of carrying out 20 community-led and expertly facilitated co-design workshops, and we're working to generate 6 interventions. Here are our stakeholders, our key stakeholders that come together for those workshops. So we're working with the NHS, of course, different types of stakeholders through the healthcare systems, from primary care networks to colleagues from integrated care boards and social prescribers. We're working with local authorities, both culture teams and park teams, as well as public health and integration teams. We're working with assets, and so public libraries, museums, various museums are engaging with us and are listed here, and also parks. Community enablers, organizations like Bromley by Bow and Neighbourly Lab that some of you will be familiar with. and creatives, people who can help lead, bring creative solutions to those problems, as well, of course, as the team of researchers, community leaders, and experts. And those are the interventions we're currently in the process of designing. And I should say that we are very much in the process. So we haven't fully pinned them down yet, but also we're really open to getting feedback, coming to talk to fora. So please do invite us if you think those are relevant to you. We'd really value feedback, and any opportunities for further collaborations we're very open to. So we're looking at developing potentially training and experiential CPD for social prescribers that will help raise their confidence to engage with those assets. We're working with young people, and we're looking to develop youth influencer training and thinking about what this means. What do they need to understand about the impact of creative health and engaging with those assets for health and well-being, understanding mental health, developing digital skills, and developing some social prescribing techniques.
Maria, just to wrap it up now, if that's okay.
Wrap it up, yes.
Soonish,
and so
yeah.
Other interventions are around community access schemes, a digital tool for mapping, asset mapping, and looking at the role of libraries for social prescribing. And that's it. Those are just some of the reflections from the experts. Thank you very much for your time.
Thank you so much, Maria. That's fantastic. That's been brilliant. We've had 7 very different, very interesting, very stimulating presentations of the 91 that are in the report. So do have a look at the report. And I'm going to hand over to Susan now, who will chair the Q&A.
Yes, thank you to all our speakers. That's been truly very stimulating, and I'll just take questions in the order that they arrived in the Q&A. So there's a the first question is to Lynette, and it's a question around the use of rap and lyrics in music therapy, and wondering if that has been captured in your research and thinking, Lynette.
Yeah, so in my thesis and my literature review, I do look at research exploring the benefits of using rap in music therapy, but also using rap-based interventions. And so the research suggests lots of positive outcomes for mental health, including stress reduction, social connection to others, reduced anxiety, for example. But the reason I wanted to look at rap kind of outside of services or therapy is because a lot of Black men aren't reflected in services due to struggling to access them. So I wanted to look at how Black men create rap outside of those contexts to understand how it can be beneficial.
Thank you. And I think for a lot of SP interventions, getting people to the starting block can be a real issue. Do you have any reflections on that?
Sorry, can you just repeat that one more time for me?
Getting to the starting blocks for social prescribing can often be getting the initial involvement can be often problematic.
Yeah, and I think that's the challenge. I think that's where community services play a really important role, but also thinking about education and the role that rap could potentially play in education as a preventative tool to maybe get, school children thinking about mental health, talking about mental health in a non-clinical way. Yeah, but I suppose you're right, there is the challenge of getting people into those community services. Just thinking about how to do those, but I also talk about, the role of rappers in normalizing vulnerability and how they can almost, spread awareness and messages about mental health that resonate with people that perhaps don't feel comfortable to talk about mental health. So yeah, I think rappers and kind of artists can play a really important role too in normalizing mental health experiences and potentially encouraging people to open up. There's some research looking at conversations online that happened after rapper Kid Cudi talked about mental health in his lyrics, and what it was found that Black men had a lot more conversations about their experiences on, then Twitter, now X. So yeah, artists have a key role to play as well.
Thank you very much. So just moving along the question list. I've got, do any, this is an open question to any of the speakers, do any of the featured projects include creative writing, poetry therapy, CWTP, reflexive writing, etc.? It's a bit of an open question if anyone would like to leap in.
I think Charlotte's got her hand up, Susan, so she might like to answer that one.
Charlotte, to you.
Yeah, I'd just like to highlight firstly the What's Your Story programme very much leans into creative writing processes to help people express themselves and express their lived experience to help shift some of those power and values. Equally, we're also, one of our community innovation teams are using creative writing sessions with high intensity users of accident and emergency departments, again, similarly to allow people to express their lived experience and to really try and unpack some of the reasons why they don't feel like they're getting their support they need. So that was just from my side. I wanted to highlight some of those particular activities.
Thank you. And we've got another hand up.
Is that me, Amina? Yes, okay. Yeah, I was just going to add to that. I'm also from the Recite programme, and we have some of our teams who are actually doing script writing, poetry writing, you know, developing and designing comedy workshops, you know, stand-up performances and, you know, other things as well. So there's a lot of creative writing going on.
Thank you. And Maria also had a response.
Yes, I just wanted to say we used in the Abundance Project, we used, as I did mention, lived experience storytelling. And I guess one of the challenges with that is language as a barrier. So very much thinking in terms of creative writing in particular, thinking what this means. I have used this previously in all sorts of workshops with underserved communities. And I think one does need to think, well, you know, how do we go about language being a barrier, how we can use multilingual approaches, other types of input for storytelling, etc. Also, in terms of lived experience, I would say that the need is for awareness around trauma and the possibilities of re-traumatizing participants. So really impactful methods, but with awareness around those potential challenges.
Thank you, Maria. And I've got VM wanting to say something. Sorry, you're just coming up as VM.
Vanessa is actually in the audience as an attendee. So you won't be able to see Vanessa, but we can hear you if you want me to try and unmute you. So let me just try and do that now for you. Right, Vanessa, you should be able to speak, possibly. Try.
Yes, can you hear me?
Yes, we
hear
can.
Me?
Yeah, we can, Vanessa. Yeah.
Yes, I mean, one of the main, there's an awful lot of there's a big history of creative health and it working in so many ways. And I run a social enterprise using photography for wellbeing, and there seems to be a really big elephant in the room in some ways, in that the funding is ever shrinking pot for people that set up social enterprises working with dance and the arts and theatre, and it seems that when we're being encouraged to connect with universities so that universities, you know, rubber stamp what we're doing or prove that it's working, and yet there's this this assumption. I mean, the people working in this area are often working hand to mouth because they're passionate about what they're doing. And then the ideas get picked up by the universities. And I just wonder, where is the funding for the people who are running all these creative projects?
Would anyone from the presenters list like to leap in and attempt to answer that?
Yeah, certainly. I think I glossed over the resource constraints that we sit in and the system constraints. And it's a big part of Recite is looking at how we might start to mitigate and overcome these. And it is by no means a small challenge, and it is nothing. It's not one we're expecting to solve in the next 3, 4, 5 years. It's going to take some real fundamental changes in how we fund healthcare, where that funding comes from. At the moment, we are relying on a lot of pragmatic, altruistic individuals that are able to string together small pots of money and try to use it strategically. And at the moment, it's about the best solution we've got in the current environment that we're working in. It's not a solution, but I think the more we can use to highlight the kind of impact that you can have by stringing these small pots of money together, while also really speaking about the fact that you are still limited in what you can do, and then the spread of that resource as well to going to the people that are delivering on these interventions versus the academics that are doing the research for it as well is another big thing that we need to be talking about, advocating for, and continuing to highlight. So I think that's just from my side to respond in part to that.
Thank you. Maria, next.
Yes, I mean, I agree. It is a huge challenge, and we find that all the time. And, you know, I have worked as a community participation officer before. I know very well the challenges. There's also huge challenges within the higher education sector in the UK, as we know, particularly arts and humanities were collapsing, you know, for lack of a better word. So there aren't any easy answers, I'm afraid. But what I would say, I think an example of good practice is the Mobilising Community Assets for Health Inequalities programme funded by the HSC and UKRI. And we have community leaders as co-investigators in the team. The community organisations are paid for their time, for their contribution. You know, we are collaborators on, you know, there isn't a hierarchy there. We are a team working together and bringing different types of expertise to that work. And that is very, very important. And also very important to, of course, remunerate the lived experience experts for their time and contribution, acknowledge their inputs, co-author work with them. So all those ethical approaches to kind of collaborative and work and co-production, I think, are hugely important. But there are no easy answers, I'm afraid.
Thank you. Thank you.
Thank you. I've got Lorna Greenwood showing on the screen.
Oh, hi. Sorry, I'm Lorna. I'm from Breathe Arts Health Research. I work collaboratively with Dr. Katie Hazelgrove on the SHAPER study, which is why I'm here for the Q&A. And I just wanted to add to what Maria said really there, is that we're a small not-for-profit social enterprise. So we experience all those same funding constraints and challenges that you've just mentioned. But with any research bids or research that we've collaborated on, and we've really tried to ensure that we've costed our time and costed the, you know, what's required to actually make these interventions happen within the research bids. And that's about being really realistic with that time required, not just for the delivery of it, but also the collaboration on the research. So that's really important. And then obviously we hope that with this research that we've produced collaboratively and that you know, Katie's presented on today, that will help us make the case when we go back to, you know, community outside of research and our kind of standard day-to-day, really make the case for making our work sustainable and securing sustainable funding to secure its future.
Thank you, Lorna. And
Susan, we've got a few more questions from the audience, but I'm wary that we've got quite a lot in the Q&A. So I don't know if we should go back to the Q&A where people put their questions and then
yes. Perhaps I could ask audience members to pop it in the Q&A. That would be helpful. So I've got a practical question coming up next, which is from Erwin, who's doing a PhD. And it involves an empirical case study at a hospital with 5 workshops, and she's been having difficulty, trouble contacting hospitals and knowing who to contact. So this is a practical question, and how to apply for funds. I would really appreciate any guidance you're able to provide with your experience in the area. So any tips for Erwin from our speakers? Be gratefully received. Anyone want to take that one on? Thanks.
I think Tanya is going to.
Yeah, of course. I mean, I'm based in Wales, so I can. We're in a unique position where we have arts and health coordinators for most of the health boards. So it's quite an interesting aspect of actually getting to know the arts and health coordinators and understanding the strategies and the priorities for each of the health boards. I don't know, other areas in the UK might have a different approach, but it's been really useful in understanding those strategies, and then that helps shape projects. You know, I'm kind of in a hybrid role because I work for a university in a capacity, but then with the Body Hotel, I'm kind of, it's a grassroots social enterprise. So I'm often kind of jumping from one world to the other. So I did want to acknowledge some of the difficulties and kind of getting to connect with people. But also I would recommend the Wales Arts Health and Wellbeing Network has different network meetings where people present, and it's a nice way, and to get to know other stakeholders in the sector. So it might be, getting to know hospitals or connecting with hospitals might be challenging, but then there's kind of different, I would say, connectors within the environment that can support. And then Arts Council Wales as well has a fund dedicated to arts health and wellbeing, which is, unfortunately, it's only open to organizations. So that's something for freelancers to consider, whether they want to become a social enterprise. But just there are kind of renewed pots of funding, and we're hoping that Creative Scotland also follows suit, and other arts councils as well. So hopefully that helps.
Thank you. Dawn, is your hand up in relation to what's just been said?
Yeah, so it's just to answer the question of Erwin, who asked for tips in contacting hospitals and contexts. So I would advise maybe looking to the NIHR, the National Institute for Health and Care Research, because they have study support delivery teams, and there's one in every region of the UK. So if you're at QMUL, that's probably one of the London ones, because that would probably be your best link into health services. I've done research before where they're sort of helping us find research sites, including at hospitals, so they could be a resource for you.
Thank you, Dawn. That is a really good tip, and it's a free service. I've used it myself. They're friendly and they're accessible. So thank you for pointing that out, Dawn. That's helpful. Are there any that I can see? We've got
a few more questions.
And SH.
I think there are questions from the audience, Susan.
Are these different questions?
I'm not too sure. Maybe we go back to the Q&A, and then anyone from the audience who have questions, either put in the Q&A or we might come back to those questions at the end. Maybe if you want to, Susan.
Please could the people in the audience with the question put it in the Q&A, and we can be more organised that way. Thank you. This is a kind of open and philosophical question that's quite interesting. I'll read it out. I would be interested in views on how best to retain the burst of energy that comes from projects that have been grown from the grassroots and started small scale, in efforts to scale up and embed as part of the health and care system. So that's a kind of quite large question. Who'd like to go first? Charlotte?
So from our experience in Recite, are two platforms around knowledge exchange and networking. So one being the Creative Health Exchange, where we're bringing health providers, creatives, local authority decision makers together to share in best practice, but also through that, we're now advocating for a creative health strategy in the region. And so that's one way to try and keep that momentum up through trying to break down some of those silos. Equally, we also have our learning events, and that's where we put our community partners central stage to showcase their achievements and again really challenge that status quo together with both local stakeholders, but we're also planning then a big one at the end that will link up with national stakeholders, so bringing everyone from, for example, UKHSA, things like that. So where you can, creating these platforms and spaces to bring people together and connect. And also, I would really encourage people to take a creative approach to these platforms. So avoiding, you know, too much PowerPoints, make them very kind of vibrant marketplaces and things like that. I think that's something that we do really well in the creative health space. So that's one way we're really trying to keep that momentum up and really platform these grassroots initiatives.
Thank you, Charlotte. Was there anyone else from our speaker group that wanted to respond?
I think Amina might have had her hand up, and Sophie.
Amina first.
Yeah, I just wanted to add to Charlotte's point, and also from the Recite project, that now is a perfect and ideal time to harness some of the momentum and energy that exists with the discussions around the neighbourhood health plans, particularly. A lot of the different creative and community and health stakeholders in this space are delivering things, but actually it's a real opportunity to bring that together and align it with plans for neighbourhoods and those broader systems. So I just wanted to add that point.
Thank you. Sophie.
I just wanted to come in on the creative methods in order to have this sort of knowledge exchange, because I ran an activity with the wider public health team, which was effectively a game of Cluedo that looked at the kind of health problems and the issues in the city, and then scale out to think about how institutions like the museum could impact some of those groups and some of those issues affected. What it kind of did was gamify the way in which we think about the problems, and how actually there's quite a lot of overlap in between the work that the museum is trying to deliver in terms of its social impact and value and what the public health team are already doing. And by inviting them from all across the kind of public health spectrum, there were loads of different ideas that were formulated out of that about how to move forward and working together in that way. So I'm very pro gamify the interventions if you can.
Great, thank you. I'll move on to the next question. We've got one about Recite is a good way of behavioural modification to establish equity, and it's someone who works with limited resources in a region in eastern India. Does your study find any real difference in behaviour modification based on who the teller is, like a respectable or maybe trustworthy person who has? Well, this is a difficult question.
I do know the question. We have read it. I'll jump in quickly, but then I'll hand over to Dawn. I think it's just to say that within Recite, our focus is more on how we can use storytelling to shift power and values, and then create environments in which people feel then more capable to take on positive beliefs and behaviours. So it's kind of playing the long game, as opposed to what we often see is whether we've got some of these trusted messengers to kind of really sort of push people into certain behaviours. And I think that's something we've seen reflected in a lot of the presentations we've heard today, that behaviour modification isn't necessarily the direct goal, but we see it as the long-term benefit. I'll hand over to Dawn, because I know Dawn has some interesting thoughts on this as well.
Yes, well, speaking as a behavioural scientist in my background, I think when we're talking about behaviour, it's kind of what behavior are we talking about and by whom. And the way we're looking at storytelling and recite is on a systemic level. And we can see that it's got power on a lot of different levels, as Charlotte said. I think often in the health services, we think about it as who are our trusted messengers telling stories, of course. And our idea about behavioral modification there is that we want people to engage with health services. We want them to take up the offers, and we want them to change their behaviors. And so we know that actually we're working with communities and the trusted messengers there. It does work, and the storytelling enhances that community outreach. But that's only one piece of the puzzle, because we need to think about behavior change from commissioners as well, from those making decisions. And so storytelling there actually bridges the gap in trust between the decision makers and the people who are experiencing the health equities, to actually build trust in the realities of people's lives, to enable them to take that perspective and therefore maybe create change from a structural level. And that's something we're really hoping to target and recite. I'm quite happy to invite Aidan, our storytelling, our theatre partner, if he wants to elaborate more in there. But there's also another point, which is to build confidence in people to change their own behaviours. And we see that through the What's Your Story program, through our creative partners writing on the wall, because it's actually building confidence and enabling people to be able to advocate themselves and for the care they need. Here we go, Aidan. You want to explain a bit more about that?
Yes, hello. Am I audible?
Yes.
Thank you. So just to follow on from what Dawn was saying about behaviour change, if that is indeed the right word, at the level of commissioners and sort of higher echelons of health policy making and so on, we have a take on that where we use a kind of approach which some people have referred to as looking up rather than looking down. So in other words, a lot of research in these contexts, looking at health equity, focuses on the people who might be regarded as being at the wrong end of the balance of health equity. And in fact, the participant groups that we work with are often very tired of being treated as subjects in this way. And so we use drama in the advocacy process to mobilize their ideas, our participants' ideas, about what might be going on at the higher levels of policy making. And this means, although there's not probably enough time to expand on this in great detail, what we're doing is we're constructing a kind of system of engaging policymakers at various different levels in a series of performances that we'll be doing around the 3 boroughs in the Merseyside area that we're working in. And we've got various different strategies for kind of working with those policymakers and enabling them to then take arguments further up the policymaking ladder, if that makes sense. And one of the key aspects of this is that the stories that we're telling have a kind of, several people have referred to this already in other presentations, but the non-verbal is incredibly important in this. So by bringing these policymakers from different levels into the performance spaces, which are community spaces as well, they are affected by the stories in a way that they can't necessarily immediately articulate. But what our work so far in this context and others has shown is it's that affective nature of them getting involved, if you like, being there with people who are experiencing specific things and with all the kind of allies that those people have and witnessing things, it makes them much more likely to seriously consider the possibility of deep change in the systems that we're working in and also trying to change. I hope that helps.
That sounds brilliant to me. And how do you get the people in the first place? Because it's that barrier to participation that's often difficult.
Well, how do we get people in? I'm going to ask Amna to come in on this one because she's in a very good place to answer that, because that's her, one of your main roles, isn't it?
Yeah, within Recite, we have a team of community mobilisers who work really closely with all the different stakeholders, work with creatives, work with community partners. So they're that interface between the Recite partners and all of the stakeholders across the Liverpool City region. And basically, it's been about building the trust, building the relationships, supporting, mentoring and coaching different partners. We talked a little bit earlier about resource and the challenges around resource and the benefit to working with the Recite team and the community mobilisers has been, in effect, people have an additional support network where outside of a lot of those organisations, we're able to help them to connect to different community partners and creatives and build those bridges, whilst also supporting them to put systems in place that they can build on beyond the scope of the project. So building some capacity in there. I think we've done everything from, being boots on the ground to amplifying key messages to rallying and mobilising different partners and stakeholders. And all of that has been a strength of actually getting involvement whilst also building trust.
I think that's really helpful, and really, I think, very helpful to the whole SP sector to hear that from the speakers. Anything else on this one to add? Charlotte?
Yeah, just very quickly, like I say, once again, singing praises of our community mobiliser team. Some of them also come with backgrounds, having previously operated as a social prescribers. And so it's knowing how to create that time, that space, that resource to try and make these kind of points of interaction, points of advocacy accessible. And that is very challenging to do, often in quite time constrained and resource constrained settings as well. But we see just how important it is, because like you say, often it's the voices that are hardest to reach, although we don't like that say, it's the ones that hardly get reached because we just don't necessarily have that time and capacity to make that space an opportunity for them. So I really do want to sing the praises of our community mobiliser team for also helping to create that in our programme.
Excellent. And any more on this particular thing, because it does seem like a central issue, before we move on to the next question? Okay. Yes, I've got AJ. Sorry, you're not coming up as a name.
I'm sorry. To be saying Aidan Jolly Collective Encounters. Yeah, just to say very briefly, time and in-depth engagement are absolutely crucial here. The longer we can stay engaged with the communities that we're part of anyway, the more these kinds of links and networks can be built. So it's absolutely vital that we work to build really sort of sophisticated and interlocked networks of knowledge locally over long periods of time.
Thank you, Aidan. I'll take the next question, which is directed towards Hazel and the Shaper project. And Paulina says she's got many questions, but I'd love to hear in detail the nature of the singing sessions, singing with babies, singing alone in choir, etc. Thanks is the question.
Yeah, I can jump in and answer that one, and maybe Lorna as well, as Lorna's from Breathe, as his mum say. Yeah, so I realised I didn't really talk too much about what the singing sessions involved. I was so excited to share our findings. But yeah, so it was singing with the babies, so with mum and baby pairs, and they were hour-long singing sessions. And I think, Lorna, if I'm not wrong, it was sort of groups of around 10 mums. Is that about right?
Yeah, that's right. Yeah.
Yeah, and as I said, we had sort of specialist music leads who would deliver the sessions, and using this sort of repertoire of international songs and in a range of languages, so it's accessible to mums from different backgrounds, coming from different languages. And I guess perhaps Lorna, I'll let you talk a little bit more about it.
Yeah, I can add. Thanks, Katie. So yeah, I think something that's really important to say is we always say to in all of our promotional material for Breathe Melody Swans that no experience of singing is required. You don't need any experience to join our groups. And so that's important as well, because although we're facilitating group singing, as Katie said, these groups in Shape are around about 8 to 12, but actually now our groups tend to be kind of 10 to 15 mums and babies. It's really important to say we don't kind of lead up to a performance or anything like that. It's really about the singing in the room and the experience together, singing collectively in the room. And I think something else that's really important to say about the programme is that it's very focused on the mother. So as Katie said, we don't use kind of nursery rhymes. We use quite a range of songs in different languages and really try to work to creatively challenge the mums That said, you know, the repertoire we use is really tailored to symptoms of postnatal depression, so very short, simple lyrics that can be easily remembered. And actually then we can build on them through the use of kind of rounds and harmonies. So hopefully that brings it to life a little bit.
Thank you.
Before we go on, Susan, I know there's two questions for the audience, but one audience member said they would like to verbally contribute rather than put in the Q&A because they find it a bit easier. So I don't know if you want to do that at the end or whether we do that now. Up to you.
Oh gosh. I'll take the next question from the Q&A and then we'll perhaps do one, like we could alternate, I guess.
Yeah, so do the Q&A and then we'll come back if that's okay. Makala, I hope I said your name right, and we'll come back to you and Marion in a little bit.
So this is a question for Chloe about her work in the care home, and which Andrew says is truly amazing. So what plans to research the effects on whether these approaches change residential care units' use and dosing of use and dosing of medications? So does it make a difference to the use of medications, admissions of residents from residential care to hospital experiencing distress, and other indicators might mark a more humane approach to managing distress, etc. So it's sort of context and influence on staff.
Oh, that's a very good question. There are plans, yes. Now, funding is very difficult to get for this work, obviously. It's a very niche work, it's very embodied, and doing a randomized control trial is not always the most appropriate tool either. But I'm very slowly going back to what was said before, trying to build a small pot of funding to try to devise an intervention that would have an artist embedded in a home, do a little bit of measurements on trying to evaluate if residents have less distress behavior, if the medication can slowly be lowered, and then working from here to bigger pieces of research. But yeah, it's difficult because it's this kind of middle ground between arts and health, which can be a bit too much for a health funder. It's quite out there. So we have to go very slowly with small pot of funding for more experiential work and very progressively build it up.
And I think there was a question earlier on in the chat that we might have passed over by accident, or I might have passed over by accident, about support for staff using your approach. Have you thought about the kind of extra support that staff might need?
Yes, so what I didn't have the time to say in the presentation, and I also saw the question about ethical approach, is that that's really important in the work of Enteleki. They don't just show up to a session just like that. They have a 10-year relationship with a care home. So they spend an awful long amount of time building the relationship, not just with the resident, but with the whole care home. It's a whole home approach. They know the staff joining the session. Before to do anything, they were just hanging out, having conversation, having tea and coffee. And that is the ethical approach. So those staff in that room at that time knew them, knew the work, had been there before. And something that's really important is that at no point the artist contradicted the care staff that say, well, you've been changed. They didn't say, well, maybe you didn't change them, and argued against them. They supported the person in the feeling, but they didn't go in contradiction to the staff either, because there is so much ethically for everyone involved. So it's very important for them to hold the space, but to not neither create conflict with the care staff, because that could impair the relationship with the resident. So there is a lot of really, really deep, sensitive work that has been going into that process over the last 10 years.
Thank you. Shall we take a question from the floor?
Yes, Susan. Let's take McCullough Ellisy. I hope that's how I say your name. I'm just going to unmute you. I'm sorry if I've got it wrong. I just allow your mic, and if you want to try and talk now or unmute yourself. I don't know if they're there. If not, we'll go to Marion. If not.
Hello, hi.
Hi, sorry if I got your name wrong,
sorry.
lovely.
Yeah, it's Michaela, but I'm
Michaela.
used to it. It's fine.
Sorry about that. I didn't know if it was
No
Elsie or
worries.
Michaela as well. So
Elise is my middle
Elise
name.
is
For
your
some
name.
reason, it's registered on there. But
Well, welcome.
no worries. Thank you, everybody. I just want to say it's been really refreshing to listen to people who are passionate about arts in health. It's something that I don't really encounter at my university, which is the Queen Mary University of London. There are very few of us that kind of work in this field of arts and meeting arts and health. And currently I'm looking at how Black women use poetry to navigate challenges to their mental health, you know, before, during the COVID pandemic and since the COVID pandemic. It is the first study of its kind, and it's been mind-blowing and quite traumatic actually in places. It's a decolonial project, which brings me to my question about decentering as practitioners, as researchers, as clinicians, as academics, and even people on the ground who have been elevated into positions of power. I just wanted to have us think about how we decenter ourselves and the kind of universality of knowledge in, you know, what we consider to be good health. I heard someone mention something around behavior change, which is, for me personally, a problematic phrase. But then someone else spoke about values, shifting power and values, which I thought was quite a poignant phrase, because when I think about power and values, I think about whose power and whose values, and how I wanted to know how the researchers and the people that present today, and also those of us in the room that are doing work on the ground, how we think about our positions of power and how we put our own values onto minoritized communities, as opposed to taking on what their values are and shifting, you know, decentering ourselves and centering their perspectives and their lived experience. Because, you know, experts by lived experience is a phrase that is often thrown around, and you often see it used to kind of appease the community and bring them into the room, which of course is really important. However, you know, how are we making sure that we are not furthering this kind of universal ideology around what knowledge is, what health is, and what values are? You know, what practices are we taking on to make sure that we critique our own perspectives and where they come from, and the structures and institutions that inform our own learning and ideas around what health looks like?
I think that's a brilliant question, and I imagine each of the speakers will have a perspective on that. So I would invite the entire panel to contribute with a response in any order you like.
Thank you.
Maria's got a hand up, so I'll let Maria
thank you
respond. Hold on a second.
Thank you. A very important question, and I would say, first of all, you know, we're really aware of power issues and dynamics, and that is a very important consideration for us, and I'm sure for many colleagues here. And I would say for us, the key points are two, perhaps. The first is, as someone else previously mentioned, commitment and long-term relationships. So making sure that we're not opportunistic in our approach in terms of working with communities. So, for example, for the Abundance Project, the partnerships were there. We've been working with some of those communities for years, some of the researchers in the team. There's place-based partnerships, there's partnerships through kind of common interest and practices, but those are established partnerships. And of course, that doesn't mean that we don't work with other people, but I think not being very mindful and not taking an opportunistic approach to partnership, I think, is really important. And the other thing I would say is what I mentioned in the presentation is co-production, co-design, making sure that we don't design the project, we don't do research on communities, we do research with communities. We are members of those communities in different ways as well. We have lived experience too. Personally, I was born a refugee. So it is about just making sure that we are very aware of the power dynamics, and we take a very conscious ethical approach to co-production, co-design, collaboration, so that we diffuse the power dynamics in this way. And money is also important. We don't often talk about it, but ensuring that colleagues and community members are remunerated for their time appropriately. All those kind of ethical approaches to collaborative working are essential for the projects that we're talking about.
Thank you. Thank you, Maria. I can relate to you when you speak about being a refugee and belonging to the community in which you are working with. I think that's really, really important. And I find that policymakers can often be quite detached from the communities that they implement their policies in. So, I always think about, okay, we present these ideas and we present these findings to these people, but how do we get them to truly understand when often they don't embody the experiences in which they have power over, right? So, but yes, thank you, Maria. Appreciate your answer.
And I think, Susan, Dawn will also want to respond to Michaela's question. I think you both had your hands up, didn't you? I just spotlighted you. So
thank you.
Mina and Dawn, if you want to, maybe Dawn and Amina go. Dawn, go first, because I think you put your hand up first.
Well, I think we're probably going to tag team it, as I'm sure Amina has lots to say. That's similar to me. But yeah, I think two words that I would put out here would be ownership and accountability. So it's about who actually has ownership of the direction of the research. Have we really worked with the communities, and are we going in the directions to investigate what it is that matters to them? And I think that's always a struggle, because it's that time you need to take to engage. And Charlotte talked about this in the presentation for Recite, that the long process of designing the research before we even put it forward for funding that took place with different sectors, different people in the communities to try and pull together a program and theory of change that was truly co-produced. I mean, there's a lot of limitations and problems around working and challenges as well that our paper covers. But I think that's one of it, sort of that idea of the ownership can't just be coming from the researchers. Now, accountability is the other issue, the sort of, are we accountable to the communities that we work with? Do we actually deliver on the things, or are we just going in there, parachuting in and then disappearing? Are we actually delivering what they're expecting so that they see actual change rather than just researchers coming and going? And Amina, I think you can probably talk a little bit more about the ownership front, because I know you're very invested and involved in this part of it.
Yeah, thanks, Dawn. I was going to add, in terms of ownership, I think a key component of this is the point, to pick up on the points raised by Michaela and Dawn and others, is also recognising your role and advocacy to support some of that ownership, and listening to the teams and listening to the direction that they give you. And although that has an impact in terms of it's challenging for time constraints when you work into a research timeline, but also what that does, it contributes to building trust within the system. So recognising also for those who are in organisations, institutions where power exists, that you have a role and a platform that you can support, whether we're talking about creative freelancers or community stakeholders, that we give the space and opportunity for them to be able to step forward and take ownership of these, whether it's the intervention that they're designing or the creative output, and decide how they want to communicate that and who they want to communicate that, and the role that we take in supporting them to be able to communicate and advocate for themselves. So I think in that sense of rebalancing some of the power. There is a role for academic institutions and others to play, and it is a bit of a challenge, but also building trust in the system so that different stakeholders, whether it's creatives or community partners, feel confident that they can ask for what they need as well, and that we're prepared to listen. And I think all of those address some of the power issues that have been discussed today, and also allow us to build more capacity within a system that's already fragmented and very complex. So.
Thank you, Amina, and thank you, Dawn, for answering my question. Your answers have been, they give me a lot of hope, because I've seen and witnessed kind of very extractive practices when it comes to research on the ground. And this is problematic. I don't need to explain that to anybody here. I'm sure you're all well aware of that. But working as a TA in global health and anthropology, I see a lot of medical students coming in, and they have very kind of embedded ideas around health and, you know, social determinants and all of these things. And it can be quite difficult to get them to understand the kind of broader context and nuance that happens within cultures and societies and communities. But thank you. I appreciate your answers.
Mm-hmm. And do any of our other speakers want to respond? Because I think we're all thinking about those ethical issues all the time.
Yeah, I'll just add to that. I echo what everybody said, and I think, Michaela, your reflections are really important. I think for me, with my research, it was thinking again about co-production. I know that's been mentioned, but I worked with a few Black male rappers in the community who were able to give advice on the resources that I was sending out to participants and the interview schedule, whether they felt that was appropriate and engaging. If I'd have had more time and resource, I would have wanted to go out into the community more to speak with more of the kind of target demographic, just to get a sense of whether the study felt, you know, appropriate. So yeah, I think that co-production is really important.
Thank you, Lynette. I really enjoyed your presentation. By the way, it has parallels with my own, and my partner is actually a rapper, so please do get in touch. He's very embedded in that community, so if I can help you in any way, please do reach out.
Thanks, I'd love to connect. Thank you.
And from our speaker panel, is there a final response to that question that anyone would like to make?
Actually, yeah, I think maybe one of the things I would like to think of ourselves as researchers as is a bridge, sort of maybe connecting and helping communities to be able to fight their case to the decision makers, to properly resource the community spaces, the arts, the creative activities that are really making a difference.
Thank you. Now I can see some hands up.
What do you want to do, Susan and Alex? And we've got a couple of minutes left. Do you want to take go back to the Q&A, seeing as we just took Michaela's from the floor, as it were?
One last question from the floor, because I think we've done everything in the Q&A.
The other thing is, in the Q&A, if there are questions that haven't been answered, the speakers can write an answer. That would be helpful if you can see any questions that you haven't been able to answer.
Okay, so the last one from the floor is from Marion. So I'll just allow your mic on, Marion, if you want to, because I know you've been patiently holding your hand up. So Marion, if you're there and you want to unmute yourself and ask the question.
Yeah. Hello, thank you, everyone. I'm Marion, I'm from the UK, and I work in creative health and particularly in nursing. And it builds on Michaela's comments, but mine's about this whole world of creative health, aligning the arts and health. And I'm curious and also concerned that we are not doing the gender and equality impact analysis with many of the work that I see and I'm involved in. And we're therefore creating another, once again, women's unpaid, unseen, unvalued work in this. And as I see the rise of social prescribers, community health workers, the sort of voices on the screen, where we are once again women doing this either as a side hustle or as unpaid work. I'm just curious as are we actually looking at this creative health endeavour with that equity, mine's a gender one, lens on it again, so we don't recreate the structural violence that got us here, which means most of us are doing this low paid or no paid, or building it as a community initiative.
Brilliant final question, and we're almost out of time, so fairly quick responses, I think, from the panel, but point taken as well.
I'm not too sure if anyone's put their hand up yet from the panel, if anyone wants to just jump in.
Yes, anyone wants to jump in?
Ada wants to jump in, so I'll just spotlight him. Hold on a second.
I was going to
spotlight. A man speaks. A man speaks. Really?
Yeah, I don't have to. I'll shut up.
No, I am not shutting you down. I'm drawing attention to the world of how women are socialized often in this as well. Aidan, please do speak.
I really don't mind, but I was going to type it, then no one spoke, so I could still type it if that's better. But I just wanted to talk about the imbalance in funding and in resources between the large research institutions and those of us in communities and in small community arts organizations and so on, and that amplifies the sorts of inequalities that you're speaking about. And obviously, although obviously I am a man, the organizations that I work for and in tend to be women, female led, so that obviously reinforces the point that you're making, and the lower down the ladder we go, the more female led they often are. Not exclusively, but in my experience, this is a big problem.
Thank you for bravely leaping in there. I'm going to hand back over to Alex to thank everyone and close the event, but it's been really stimulating.
Thank you, Susan, and thank you everyone. That was great, and I'm glad we had so much time for questions and discussion. That was very rich. So thank you all for attending. Do read the report. There's also a summary version of it, and we'll get back to people about what we're going to do next. And the idea is that this becomes an annual roundup. So hopefully we can deliver that.